Hello, and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning. Before we get started, I'd just like to remind you about some of the sessions taking place at MIMS Learning Live South on Friday 12th of June. Join me in person for great hot topics and fantastic new speakers giving you insights into all the key issues that you're currently facing in general practice. For example, I'll be hosting a panel discussion on obesity, asking where GPs go from here in the company of GP Dr Patrick Holmes and consultant Dr Amar Putana. We'll also have red flags sessions on paediatric illness, ECG interpretation and neurological symptoms, as well as an update on the new type 2 diabetes guidance from NICE. And I'm delighted that we're on the crest of the wave regarding the name change and re-evaluation of polyendocrine metabolic ovarian syndrome, formerly known as PCOS, with a presentation from Dr Lindsay Thomas. There's much more, of course, and you can see the whole programme at mimslearninglive.com. Today's interview will cover the leading cause of death in the UK, dementia and Alzheimer's disease. I'm delighted to have with me today Dr Alistair Robertson, the Chief Medical Officer for the Enhanced Frailty team in North West London, and you're going to talk to us today about dementia in the context of the GP's point of view.
Thank you very much. It's lovely to be here and speak to you about dementia, something I see a great deal. In my job, I left GP a little while ago in search of other things, and that was 5.5 years ago now that I've been doing this as a full-time frailty doctor. We have a wonderful team. We cover a large area of northwest London between myself, some other gypsies, ANPs and care coordinators. We get a very broad range of patients, referrals from everywhere, the GPs, hospitals, all over the place, palliative care and the community services. They are obviously generally quite frail, complex and challenging, and lots of challenging medical and social situations. But the main thing that really separates them out is they're the patients that fall between the cracks. And that's what I enjoy about the job. What I think I enjoy doing most is keeping them out of hospital.
So do you see a lot of dementia in your patient cohort?
Absolutely. I would say roughly 2/3 maybe have some sort of cognitive impairment, I would think, and possibly maybe half of my patients have a dementia of some sort or another. But a lot of the time they don't have a diagnosis until we've got there and seen them. So there's a great deal, that's for sure.
And by definition, these are frail patients, aren't they? Moderately or severely frail.
To be referred to us, they are typically frail, but frailty and dementia are intrinsically linked.
Yeah.
We have lots of scales to measure how we look at frailty, but the frailty in dementia is measured by their level of dementia. So if somebody is moderately advanced dementia, they've got moderate frailty and so forth. So they are intrinsically linked.
So when you notice dementia, what patterns do you notice in the cohort of patients that you look after?
If you look at the research, it typically says it's more common in women. It's not something I observe in my role particularly. Maybe I haven't been noticing, but the rationale would be women live a little bit longer than men, and there's no doubt the incidence of dementia increases with age. So it's always going to be a little bit more common in that respect. But I think if you take that away, really, Alzheimer's tends to be fairly even spread. Vascular, perhaps, maybe a little bit more in men because of the cardiovascular risk factors. The only pattern that maybe is really quite noticeable are some of the less common. So frontal temporal dementia does tend to be far more prevalent in men.
You mentioned that sometimes you're the first person to make the diagnosis. And I understand that dementia is underdiagnosed because NHS England publishes data about this. So what's going on there?
There's an enormous amount of factors going on here. The reason why it is underdiagnosed, I think we generally consider that about 2/3 of patients with dementia in England have a formal diagnosis. So that means 1/3 of them don't. And that would roughly equate to about 200,000 in England not having a diagnosis. Now, I'm sure many people will be screaming, well, it's all the pressures on the NHS, isn't it? You know, it's service provision. And yes, there is going to be some degree of that, certainly. There are long waiting times. So maybe some of them get fed up waiting, some of them maybe forget, but there are a lot of factors we need to think about when it comes to this underdiagnosis. If we try and break this down, the first thing that I would think about is the amount of times I hear, "Oh, come on, doctor, all of my friends have got a bad memory. It's not just me, it's just old age." How many times do we hear that? The whole time. It's just considered to be normal aging when really this isn't. So maybe if they think to themselves, well, if I don't tell anyone about this, maybe it'll all just go away. So there are certainly denial and a lack of insight into what's going on is certainly one of those things.
But there's also a lot of stigma around dementia, isn't there?
Absolutely. The label of dementia is not worn very well by people. It's something we get very, very worried about. It's a fear in the diagnosis. What's going to happen? And I can't remember who it was that said this to me, but it stuck with me. They said, "Doctor, when you get a diagnosis of cancer, everyone comes running around. They wrap you in cotton wool. They bring you food. They look after you. Get a diagnosis of dementia, and everyone runs the other way. They don't know what to do, how to handle it. It's very unfair like that." So I think a lot of that underpins the fear behind all of this.
And what about the patients' families? Are they of the same view, or do you get a disconnect between what the patient thinks and what the family thinks?
Well, I mean, firstly, it's quite often the family that are the first people to notice something rather than the patients themselves. But the other issue that we have is when the families don't really agree on what's going on. That's the sort of thing we see a lot. So that can be quite difficult to unpick sometimes.
And I guess people don't necessarily know what dementia is, or might not even have heard of it, or might not have a word for it.
Yes, absolutely. So look, there are cultural issues. Some cultures might not have a word for dementia. They think it's divine, it's God doing this to them.
Yeah.
Or just simply a total lack of awareness.
And I guess there's comorbidity as well, isn't there?
There are other things tied up with all of this. There are quite often lots of other things going on, other medical conditions or social issues you need to factor in.
Okay, so given all of that, what can GPs do to tackle the underdiagnosis issue?
Some may lack the confidence, just might not be aware of how to refer or when to refer, or even refer to the wrong service. So certainly mental health teams like, no, this is not for us. You need to go back and do something else. So delays and things like that. Even simple things, making sure if a patient has a diagnosis, it's recorded on your electronic care record. It may already be there, but they just don't know about it. So simple things like that, certainly in the first instance, will be very useful to think about.
Yeah.
A bit of a broad understanding that dementia doesn't always present with just memory issues. That's the first thing we go to, isn't it? Certainly people who have dementias that come on at younger age tend to take much longer to get a diagnosis because maybe they don't have those classic things. So those are the other things. And there was one thing that dawned on me is that modern primary care, the nature of it is this lack of the continuity of care, which means we don't know our patients like we used to. And as you don't know what they used to be like, you don't know what they are now. So that little snapshot you get in your brief 10-minute appointment, it's very hard to know where they've come from. Are they like this now? Have they always been like that? And that's one of the aspects of my job that I enjoy very much, is I get to see people through those journeys as well. But of course, there are lots of other barriers in the assessment and diagnostic process as well.
So say I'm at GP during this appointment. If I'm lucky, I might get more than one appointment with the same patient, but maybe I don't. So what are the differential diagnoses that I'm keeping in mind when I'm thinking about dementia?
Well, I'd be thinking certainly in older people, depression. Depression is very common in older people. Dementia is very common in older people. You can get depression in dementia. It could very easily be put down to that. Delirium as well. It's very common in frail patients, very common in hospitalized older frail patients as well. So sometimes we need to let that settle down after an admission to make sure that we're not confusing a lingering delirium after a hospital admission with the dementia, because delirium will give you can have the same sort of cognitive issues as well at the same sort of time.
And what about other differential diagnoses, such as, I don't know, guess drug problems, whether it's like drugs that you take like alcohol or medications that you take?
I don't know why we don't ask about alcohol. Why don't we ask more? Maybe we're embarrassed. I don't know. You're allowed to have a drink as an older person, but I think you need to be mindful that it could get a little bit too much, especially if you're depressed. Polypharmacy is another one. So older people collect medications, and these can certainly have an impact on them. The anticholinergic drugs, particularly the ones that are the culprits here. We think a bit about the reversible medical conditions. For me, really, I mean, things like B12 deficiency, we get a little bit obsessed with that as a cause, but really in my experience, it tends not to be. I think we're much better at picking that up. But maybe gross hypothyroidism and hyponatremia are more common things that you could pick up and make sure that they're maybe not the cause. And other things, chronic subdural, that's the sort of thing that might be floating around. But again, you really might have a better idea about some of the clues with all of that, if they're anticoagulated, falling, frail, that sort of thing.
And on the medication review and polypharmacy side, do you find that where deprescribing happens, that it actually is beneficial for people with dementia?
Absolutely. Recently, I went to see a patient for the first time. They actually collapsed while I was there, stood up from the sofa and collapsed in front of me, which was frightening. They were okay. Picked them up, sat them down and dusted them down and tried to figure out what happened. And I did some blood pressures and a blood sugar and had a good look. And very fortunately, there was some very sensible family on board. We had a good look at medications, lots of analgesia, overuse of opiate stuff, blood pressure medications, unnecessary diabetes medications. So we put the pen through a lot of these. Now, that patient did have an underlying dementia, but they perked up so much when we just stopped their medication. Such a considerable improvement. So yes, it really does work, and don't be afraid to do it.
So I'm thinking about my patient in front of me as a hypothetical GP. What investigations, when should I refer, and who should I refer to?
When it comes to investigations, the most important thing to think about is the history. It is all in the history, as it always is. Collateral can quite often be the most useful. So the families, who knows them best? It's finding out what they were like, how they've changed, and what they've changed to. How is it impacting their life? What has changed? They used to be able to dress themselves every day, doctor. Now the carer has to do all of it for them. Or my mum's called me up. She's struggling with breakfast. She's left the milk on the stove again. It's not like her. She's always been very, very good at this. So those are the sort of things that we need to pick out of the history. So as we said, patient themselves might be in denial. They might just not think that anything is wrong. So finding out those changes from the baseline, what has happened, is certainly the most important thing. What is out of character for them, particularly.
Okay, and in terms of signs and symptoms, what would the GP be looking out for?
So the classic stuff, maybe more the textbook stuff. For Alzheimer's, it's the short-term memory is really quite common. Word finding issues, concentration, things like that. They may still be able to remember historic things very well. So they may drive the conversation away from what you're asking them to something that they find more comfortable. Alzheimer's is a very slow burner. It's, if you think about a little drip at the bottom of a barrel, slowly cognition is just slowly dripping away. So day to day, you might not really notice anything. Very slow. One of the things we often notice is what we call the head turning sign.
Oh, okay.
So patient comes in with their partner and you ask them a question and they look to their partner. What's the answer to that question?
Okay.
And they go, well, did you remember it? It was last Tuesday when the grandkids came round. You're like, okay, all right. And how do you get on with your medications? How do I get on with my medication? So they're constantly looking for reassurance because they can't actually quite remember what they're doing. And this is something we see a lot. And that's called the head turning sign. And that alone will get your memory clinic's attention, certainly. Vascular geriatrician told me their experience was certainly more of a depression-like presentation. Textbooks will say it's more changeable, stepwise, fluctuating. It's not slow and steady like Alzheimer's. My personal experience, maybe not quite as clear-cut as the textbook ones, and vascular is often tied in with Alzheimer's as well. So the textbook stuff doesn't ring true quite as well as the Alzheimer's. But as I said before, not always memory loss, certainly in the younger ones, in the earlier presentations, so, 60s, 70s, thinking about things like FTD, so frontotemporal dementia. You might just see language disturbance, behavioural changes, lack of empathy. All of a sudden, they just don't care. I don't understand, doctor. They just don't care about me anymore. Or there may be inappropriate comments, or sometimes unusual things, new cravings, desperately want sweets. And don't forget, there is always a great deal of crossover with all of these things, like many conditions.
What about the role of things like cognitive assessments?
There are loads of these things are out there. They vary from almost a question through to very comprehensive things. So in our area, we use the ACE-3, which is the Addenbrookes Cognitive Examination. This is a very comprehensive test. It's very thorough, but it can take a little time, so perhaps not very suitable for GPs particularly. There are modified versions, which I quite like, the mini ACE, and the GPs are using their GP Cog, SITSIT, AMTS. They're just basic tools. They are not diagnostic. They're just used to see whether you need to do something else. That's all they are.
And are there issues or pitfalls that you can encounter with using these tools?
Very much so. I mean, these tests are not suitable for everyone. So if you think about people who don't speak English as their first language, a limited education, particularly maybe not grown up or lived in the UK for very long periods. So they're going to be at disadvantage straight away with a very kind of Anglo-centric test.
So is there an alternative that you can use in a patient for whom you feel that the standard tools aren't suitable?
There's something called the RUDAS, which can be used. I mean, this is designed to try and, minimize the effects of the cultural learning and language diversity. So, which doesn't necessarily mean you need to know something about UK culture and that sort of thing. You've got to remember that conversely, bright people may score higher in these cognitive assessments as well, in any assessment. So people who are good at puzzles, bright, high levels of education, they actually might have fairly equivocal or even what might be considered a normal score on some of these tests, even the very comprehensive ones. So it's not the be all and end all of the assessment process. It is just one part of all of it.
And what about things like blood tests? What would you recommend there?
Most memory clinics, which are the place where most people will be going, will be expecting some sort of delirium screen. These are fairly standard bank of blood tests, which will typically trying to rule out anything reversible. Is there anything that we can do something about? What's masking this? Mostly they're worried about infection. If it's elderly people, that's usually being accused of having a UTI, so they want to have a clean MSU result. But then what happens if your patient is in pads? They can't easily get one of these. So these are other things that can be blockers as well to referral. And again, as I mentioned before, they normally come back pretty clear. A couple of things show up, but these vitamin deficiencies and things, I tend not to really see any of that.
Okay, and what about imaging? There are brain scans, but when do they come into the picture?
We can't scan everyone, but I think if your suspicions are strong and you have met somebody and you think, look, I'm quite confident of this, I think if you can get brain imaging, it would be very useful to present along with your findings, any clinical assessment that you've done. So when they're seen in a memory clinic or by whoever they go to see, they've got all the information already there. So I think, look, if you're confident there's something going on, don't be afraid to make a request. If you can get an MRI, if that's not possible, claustrophobia, frailty, pacemakers, things like that, a CT might be pretty good as well. It is key to understand, though, that the brain imaging, this is not the diagnostic tool. It's something we use to support everything else that you've done so far. Okay. Now, yes, there are some signs that we see on there, particularly with something like Alzheimer's. Our brains shrink as we get older. Okay, there's nothing we can do about that. That is normal. Our brains shrink. However, sometimes the sides of the brain, so the temporal lobes, may shrink disproportionately to the rest of the brain. Now, that's something that we might look at. And there's a score that radiologists will use to tell you how much that shrinkage is, called the MTA score. So make sure if you do request imaging, you say, I'm asking you to do this to see if there's any signs of dementia, not just brain scan, please.
So then you get a useful comment back.
Yeah, absolutely. And they can do their scores. They also look at small vessel disease as well, and at least tell you what's the burden of small vessel disease as well. Because again, it's a very common finding, but we want to know how much is there. But a negative scan doesn't mean there's no dementia. Positive scan doesn't mean there is. It's all about what's going on with the whole picture, but it is useful to support. So if, for example, you felt that your patient had very strong suspicion for Alzheimer's, poor short-term memory, disorganized at home, forgetting medications. They've scored very poorly on cognitive assessment. I may be confident enough to say, actually, look, I'm happy that what I have is enough. You may have family who are going, well, we're still not sure about this. I've heard that imaging might be helpful. You could do your MRI. You could look at the result and say, actually, look, the MRI as well is really supporting this. So it could provide a little bit of reassurance that you're correct, point away from other things and help reinforce your diagnosis. But it's not the be all and end all of the diagnosis at all.
So would GPs generally refer to the memory clinic before that diagnosis is held to be the correct one, or would they generally just proceed without a memory clinic referral?
That is going to depend clinician to clinician, how confident they are with all of that, how long you've been doing the job, how much you've seen of it as well. So it is not beyond a GP to say, I've seen enough, I've seen you a few times now, I've heard enough, we've got positive imaging. Perhaps the family going, oh, look, you're absolutely right. We all know it. Where do we go from now? And save yourself a referral. You may also be able to email them and say, look, I've seen this patient. You happy with this diagnosis? Email back, yeah, absolutely fine. That's great. I'd suggest X, Y, and Z as the next step. That could be one way. But alternatively, if you're not sure, or if it's early on, then maybe that's the time to be thinking about a referral.
And so once a diagnosis has been established, what are we looking at then? Obviously, there are drug treatments. I'm aware that there are different ones, but I'm not sure how effective they are. It'd be interesting to hear more about that.
The current NHS drug treatments, they are, and again, some GPs might be comfortable starting them themselves. They've been around for a little while. The first line are the acetylcholinesterase inhibitors. So this is donepezil and rivastigmine, most commonly, less commonly galantamine. They try to increase the levels of acetylcholine, which is the main neurotransmitter in the brain that makes the neurons function and speak to each other. So typically donepezil's first line comes with tablets. It's fairly well tolerated on the whole, sometimes a few side effects, maybe some loose stool. Again, it might sort of resolve, but fairly benign medication on the whole, although sometimes people might be reassured to get an ECG before they start it because of some conduction abnormalities. And perhaps a caution in COPD and asthma because of bronchoconstriction. Right. So that's typically first line. And I think there are plenty of GPs out there who are comfortable in initiating that themselves. You do need to make sure that you manage their expectations on how beneficial they are. Their effect is generally pretty modest, can help a little, but I think making sure you just say, look, it might slow things down a little bit. It might benefit a little bit, might see a little improvement on some scores, maybe early on, but try to make sure that they don't think that this is going to cure it. That's the important thing to remember.
And what about other options?
So some patients might not like tablets or be able to tolerate tablets. There's rivastigmine, it comes as a patch as well. If tablet's not suitable, they just feel a bit more comfortable. There's something you use certainly in dementia and Parkinson's, similar sort of cautions as well to donepezil. But I would say you need to be very, very cautious and avoid antipsychotics, certainly. I mean, certainly for some patients, it can make things worse, much worse. So avoid those. Frontal temporal dementia, we don't use these medications. There are other things we tend to use, sort of antidepressants, really. There's just no evidence base for it. And one other you might come across is memantine, works slightly differently to those medications, which is second line if those first ones are not very effective. They have to be, again, start low, go slow, bring them up. And sometimes they have a nice little starter pack, which has got it all nicely laid out for the patient. So for me, it's typically used challenging behaviours in sort of more moderately advanced dementias. So there are a few out there.
And there are some newer medications that are becoming available? Yes.
When they're going to become available on the NHS, we don't know. We're talking about lecanemab and donanemab. They are very expensive, and NICE considered them to be a lack of efficacy and value for money. So I believe they are going to look at it again this year, but they're not very practical. They're infusions, so you have to go somewhere to have an infusion. They might be infusions that just keep going on forever, or 18 months. And the other factor is that there are some rarer side effects. You need to scan people. So you need to MRI quite a few times in the first few weeks to make sure that you're not getting any of these.
Okay.
So it's really not very practical at the moment, these medications.
So there might be some patients that's suitable for.
I think this is a step in the right direction.
Yeah.
Seems to be the impression I get from my colleagues. It's a step in the right direction and things will move on from there. But at the moment, we'll just have to wait and see.
Okay. And you mentioned prescribing for dementia in the context of Parkinson's disease.
Yeah.
What about the overlap with other conditions such as Parkinson's?
Yeah, I mean, well, look, we see dementia in Parkinson's disease. It tends to come on a lot later. It does look a bit like Lewy body dementia, which is one we seem to be seeing more and more of. Confusion, intermittent behavioural issues, hallucination, balance, mobility, continence, rather than sort of Alzheimer's-like picture. But typically they tend to have Parkinson's first, and then this comes on later, whereas Lewy body tend to have all of the dementia-like picture first, and then they get Parkinsonism later on. That's just a way that we distinguish between those two. But it's the frailty, which is where the big overlap is really with dementia.
And we touched on polypharmacy a little bit already, but this is a major problem, isn't it, for older people generally?
Absolutely. As I said, they collect medications. If you think about every time you re-prescribe a patient, you reissue something, would you actually start that medication there and then? What are the things that might be doing more harm than good? And again, we talked about the anticholinergic burden. That's really the main culprit here, these medications, so the amitriptylines of the world and overactive bladder medications. If you ever see any of your older patients on oxybutynin, please stop it straight away, okay? These are not great medications for older people. They can blunt cognition as well as doing all the other side effects that we know about, constipation and whatnot. So think to yourself, would you be starting this patient on them now? If they came in, sat down in front of you, would you start that? If the answer is no, then start thinking about deprescribing it. And a simple rule of thumb is halve it, maybe halve it again and stop it. Simple like that.
And presumably social circumstances are hugely important as well.
Yes, absolutely. I think loneliness and isolation is a huge driver for dementia, certainly. And there was a study done in the 80s called the Nun Study. I've become obsessed with this ever since I heard about it. Right. It's extraordinary, but essentially what it demonstrated was they looked at nearly 700 nuns and they did cognitive testing on them. And after they died, they looked at their brains. And there was substantial dementia-like change in their brains of a lot of them, but in their lifetime, they had no clinical dementia at all. So you're trying to think, well, hang on a minute, why did so many of them have dementia, Alzheimer's in their brain, these classic signs, but they didn't? And essentially what they realized was that this idea of cognitive reserve and resilience, so distilling that down even further, is that their lifestyle was protective. They lived a fairly modest lifestyle. They might have a drink or two every now and again, but they were fairly active. They ate modest food, but they were social. They lived in a commune. They had people around them.
They were
and
connected.
I think this was incredibly protective for them, that they lived around other people. So loneliness, isolation, lack of social stimulation, this is a huge risk factor for dementia.
Yeah, that's amazing, that study. We've heard, I think there's an idea now that social connection is protective for older people, but that's like real proof of it, isn't it?
Yes, absolutely. Yeah. It's wonderful. I'm surprised we haven't heard of it more.
Well, perhaps we will now.
Yes.
Now that you've brought it to our attention. Okay, so just moving on to the support that GPs can offer. We've talked about drug therapy and other factors, but within the GP's remit, what can they do?
Okay. There's being holistic with all of this. And by that, I mean, look, the GPs play a crucial role supporting the patient and the families right from the beginning, not just recognizing the change and doing all the scans and bloods, but these sensitive conversations. There's some challenging stuff that needs to be done, and make sure that you can just say right at the beginning, look, this doesn't have to be the end. It doesn't have to be a devastating diagnosis. But be flexible, personalised. We don't need to have algorithms. Like, what's next on the list I need to do for you? Just understand each of these patients and their families have a unique situation to them. So they might not be easily pigeonholed into how we manage them. So I think early signposting, early honest conversations. Where is all the support? Locally, nationally, frailty teams, please refer them to frailty as well. I implore you, find your frailty teams, refer them to us and we can help doing this. And lots in the voluntary sector as well. My advice to GPs is just honesty. Just be honest about this. One of the most important things you could do is just say, this is a chronic progressive condition. It is going to get worse. Things will become harder. It'll become a challenge. So especially as things progress, we don't know how long it's going to, on the trajectory that you might go, whether it's a sort of slow or stepwise, but be mindful things will get worse. So you need to be proactive and not reactive. Think what might happen before it does happen. Don't wait for somebody to fall down the stairs, move the bed downstairs to single floor living. So think what might be happening. Honesty about the other things. Say, look, it might take you a while to see the specialist if you want to go and see them. Be honest about the limitations of the medication. So please be holistic. That is certainly my first piece of advice.
Is it difficult for GPs to have that honest conversation?
It's a really challenging area, general practice. You've got time limitations, all sorts of pressures on you, but just a few simple things just to try and get out early on, okay? Rather than diving straight in with your medications and other things, just take a time to have a think. What do they need particularly? What could be the impact later on down the line for the family, the carers? It can be really isolating looking after somebody with dementia. It's frustrating, you feel ignored, social life can go. So understanding what it's like is very difficult. Just saying, look, this must be really hard for you, but I think you're doing a really good job.
Yeah. And as well as the care and support for the patient and the family, what about the referrals and the services on offer?
There typically tends to be a bespoke memory clinic, which is where you'd be making your referrals to. Certainly in northwest London, we have memory clinics with a standard pathways. It's worth knowing that they may not then provide subsequent support. They may just be a diagnostic service. They don't like that, but it's the pressures that are put on them. So they may just be there to provide a diagnosis. They may initiate and titrate some medications, but then they might be discharged back to the GP. Memory clinics typically run by consultant psychiatrists. They're wonderful. OPRAC as well, so geriatricians. Find a good geriatrician who enjoys managing memory problems. Probably see them far sooner than you would elsewhere and give you some really pragmatic advice and help you manage the associated frailty. They'll help you navigate through deprescribing and all of those other things. So some of the more medical issues. So that's a really good option as well as the memory clinics if there are other things going on.
And what about local and national services that might be helpful to the patients and their families?
Yeah, early signposting to them as well. Alzheimer's Society website is really very good. But just knowing a little bit about your local area. For us, we have a wonderful service, Harrow Carers, who are there for the people who care. Knowing them and having a wonderful relationship with them is great because they keep an eye on the people in the background rather than the doctor-centric stuff about your patient. So that's very important.
Is there a role for other people within the GP practices now that there are social prescribing and care navigators and those sorts of roles that didn't used to exist? Are they handy in this scenario as well?
Yeah, very much so. And I hope they can start initiating some of the harder conversations. So care planning, the expression is it always seems too early before it's too late to have these conversations. Where do you want to go? Where do you not want to go? Documenting that. In London, we have the UCP, which is our online platform where we record all of these decisions. But some of these conversations, some of your allied healthcare professionals maybe have a little bit more time to speak about them. End of life preparedness, that sort of thing. Avoiding admissions and trying to say, look, at what stage do we stop doing things? It's always very hard to sort of want to stop, to not do something. But there comes a time when, having your elderly relative who's got advanced dementia investigated for PR bleeding is maybe not a good idea. It's not in their best interest. Just because there is a scan out there or a test or something doesn't mean that we have to do it. But again, it takes some time and conversations as well.
Finally, you've rather wonderful notes that you've made for this podcast. You've got this statement from a family member. Oh, doctor, my father has dementia. I don't want to get it. What should I do? What is the answer to that question from a relative?
I think GPs get asked this the whole time, and I would send them to look up the 2024 Lancet report on dementia, which identified 14 mostly modifiable risk factors for dementia. Some of these you'll already know, hypertension, smoking, obesity, things like that. But there were some others that came out of here that were really important as well. Like hearing loss in midlife is a strong driver for this. Vision loss in later life, high LDL cholesterol. So these are the things, these are right in the wheelhouse of primary care, managing these things. So I think their takeaway was that 45% of dementia cases could be prevented or delayed by looking at those 14 risk factors. The high LDL itself in midlife apparently estimated about 7% of those dementia cases. Vision loss about 2%. So wearing or referring for hearing aids, getting eyesight checked, cataracts, all those things, reducing alcohol, looking at these things. So, manage the blood pressure, manage diabetes, keep the LDL below 2. That's the main piece of advice I would be having for those anxious patients that come in and see you.
Yeah. And also keep yourself connected, I guess, avoid isolation.
Stay active mentally, socially and physically.
Yeah.
Keep your brain active, learn something new, keep stimulated.
Good advice for all of us, I think.
Yes, absolutely.
Well, thank you so much for going through this in such a practical way for GPs. Really appreciate it.
Thank you very much.
Yeah, thank you so much.
Could I say a big thanks to all of my colleagues in Northwest London that I work with, all the team at Harrow Health Frailty team, my colleagues at the Harrow Memory Services, older adults mental health, palliative care team, and also Harrow carers, who are all wonderful.
It's delightful to hear that you all work so well together, and I'm sure that's part of the picture of success for this cohort.
Very much so.
Yeah. Thank you very much for listening. This episode was produced by Jude Owen. Don't forget you can claim CPD certification for this podcast and find the notes and key learning points if you head over to the MIMS Learning website at mimslearning.co.uk. And do join us next time for our next episode.